Thanks for joining us once again here on PM Express. And as we build into the elections and as we build into August, when we're expecting the parties to outdoor their manifestos, we are going to be looking at some sectors. Last week, we had in the studio young men and a woman having a conversation with the political parties. We called it the Youth Manifesto. Today on PM Express, we're looking at the Health Manifesto. And we're going to be joined by a man who you know. He's done this work in this field for a while, and he's been kind enough to put together what an ideal manifesto should look like, what a proper manifesto should look like, what issues it should be addressing. And we're getting into that for you here on the special edition of PM Express, looking at the Health Manifesto for Ghana. PM Express is always brought to you by Syntax Tanks. It is strong, it is tough. Also, as you know, I always recommend it for you because they come durable, they have double layer, and it is also bespoke. They are across the country, and you can call them also. And you know, they have 7 years warranty. Nobody else has that. 0244-335-168 or shop online at syntexgh.com. Syntax Tanks are strong, are tough. And I was talking about Dr. Kwame Sapon. He's a CDD fellow, and he is going to co-present this with me. And you see him there. This is his work we're going to go through. And then my panelists will join me. My panelists are made up of Dr. David Tinkram. Dr. David Tinkram Chum is the General Secretary of the Ghana Registered Nurses and Midwives Association. Also joining me after we make that presentation of what the Health Manifesto should be. Professor Ernest York is the Vice President of the Ghana Medical Association. He will be with me. And then we also have the Vice President of the Pharmaceutical Society of Ghana will also join us for a conversation right after this. And I want to get straight into it with Kwame Sapon on this very important subject. And Kwame, I have been looking at your slides with a bit of fascination because of the extent of the work that you've done in distilling for us what the focus should be. There are three broad themes you plan to tackle in your Health Manifesto. What are they?
Good evening to you and all the listeners. Yes, there are three things. I mean, every 4 years, we have a situation where the political parties come to us and they tell us that they have us as priority and they tell us what they are going to do for us. But do they actually tell us what they are going to do for us, or do they do what we really need? So what I want us to look at is the importance of addressing our health challenges in Ghana. And in that, you ask the basic question, what are our health challenges? So then the second thing becomes trying to illuminate the path for people to understand, be it the political parties, be it the voter, be it the listener, what our health challenges are and how these can be addressed to ensure that we have a vibrant future. And then the fact that this shouldn't be about a particular political party, but more about the need for collective action. So at the end of all this, there will be an ask so that at least the political parties having put their manifestos out, they can inculcate these into their manifestos so they can address the issues that affect us. But how are we going to do this? We are going to look at data from Ghana. And what do I mean by data from Ghana? We're going to look at data from the Ghana Statistical Service, the Ghana Democratic Health Survey. We are going to look at the Global Health Index. We're going to look at data from the Holistic Assessment of the Ghana Health Service, Ministry of Health Program of Works. And we are also going to look at data from an assessment of our health facilities and what they have or don't have, what's called the Health Harmonization Facilities Assessment Report. So that is where all the data we're using for this is going to be pulled from. So it's not data that is unknown to either the government, the opposition party, or ideally the general public. So those are the three things we're going to do.
Now let's start with our disease burden as a country. How daunting is this burden?
Well, you see, every health system has to deal with diseases. So when I'm asked how daunting is our disease burden, I say we have a unique disease burden. And what do I mean by unique disease burden? Traditionally, countries around the Sahara, and in fact, most health systems started traditionally that way, that they had to deal with communicable disease. So in Ghana, what do we mean by communicable diseases? We mean our malarias, our typhoids, our respiratory tract infections, our viral infections, and all that, HIV, you control of them. Those that you need a vector or something like that to contrast. And then you have what we call the non-communicable diseases that start creeping in often when you start aging. Generally, when you go past the third decade of life, they start gradually creeping in. But what do we see in Ghana? Because we haven't managed to get rid of a lot of our communicable diseases, there's a doubling of our disease burden. So that is what we are trying to deal with. That is what our health system has to try and address. So I'll break it down this way. Let's look at something like the communicable disease. Everyone would know that malaria is something. I mean, we are talking about dengue fever now in Ghana, but everyone knows that malaria, and that's why a lot of the symptoms of dengue are similar to malaria. So a lot of people who try to self-medicate, which they shouldn't under these circumstances because of dengue, try to treat malaria. And why are they doing so? If you look at Ghana's health service data, it will tell you that 30%. So when you go to an OPD in Ghana, 1 in 3 of the people who is sitting there is there because they have malaria. And then when you go into the wards, 40% of the people who have been actually admitted and are being treated as inpatients are there because of malaria. This comes from the Ghana Health Service report of 2020. Then there is HIV. It's still there. It's the prevalence rate is about 1.7% of our population. So if you look at a year like 2022, you'd say that almost 350,000 Ghanaians were living with HIV or AIDS. And so when that happens, you have an issue. Then there's tuberculosis, which in most countries now is gone, but still there in Ghana. You would realize that there are about 152 cases per every 100,000 of the population. So you see, that is the first point. Do our political parties factor this in when they write their manifestos and they want to address our health issues? And why do I ask the question? Recently, we heard that medication that had been donated to Ghana by the Global Fund had been sat at Tema for over a year and wasn't being cleared. So if this is what our disease burden for communicable diseases is, you wonder how the people who were sat there while this was happening were sleeping. And so this is, and then the question I ask myself is, while they were sleeping, while these medications sat there, did the citizenry also know that this is our disease burden and that this was a scourge on our integrity as a country? So that is our communicable disease burden. But then you realize I'm giving the top line figures, but you still have the typhoid fevers, the amoebic dysenteries, the diarrheas, all still being part of our communicable disease.
And that definitely is an important point. What about the non-communicable disease burden?
Well, this is where it gets interesting. The thing about many of these non-communicable diseases, they are silent killers. Why do I say so? They never have symptoms unless you are someone who is particular about your body or goes for routine medical checkups. And that's why often you hear, oh, there was nothing wrong with him. He was just walking around. They said he had a headache or he had this. He went into the hospital and he didn't make it. And they're like, oh, gone too soon. But the point is that because of our low outpatient per capita, on average, the average Ghanaian sees a health professional once a year. Outpatient per capita is 1.13. So you have a prevalence rate of 28% of hypertension. Diabetes is about 6.3%. Then you have the cancers rearing their head, especially cervical cancer in women and prostate cancer in men, and all the other cancers like the breast cancers and all that, and they are also creeping in. Then you have mental health. 13% of Ghanaians are known to be living with a mental health condition. When you say it, people think that the way we have stigmatized mental health, we make it look as if, oh, anyone with a mental health problem should be walking on the streets or should be in contact. But we forget that anxiety, depression, all these things are mental health problems. And 13% of our population are living with a mental health problem. Again, you ask yourself, if we look at how our health financing goes, do these manifestos address these communicable,
Non-communicable disease, yeah.
And if they don't, why not?
Yeah, I mean, and that is a very important point. When I sit with my guests, we'll expand on that and also ask the question, if they're addressing it, what should the interventions be? We'll come to that and expand on it. But there's also an area that you touched on that coincidentally we've been dealing with on the news today, malnutrition. And I say we've been dealing with it today because an Auditor General report has actually revealed that the school feeding program at the basic level, we are feeding children with food that is weevil infested, has pebbles in it, some of them even have worms in it. The jollof rice that is being served the children at that level, they are adding color to it, so it looks richer than it actually should. Why is this such a big focus for you, and you believe any manifesto that is put out this year that you're currently drafting must address this issue of malnutrition?
Thanks, Evans. You've hit the nail right on the head. I didn't want to say hit a bullseye because of all the connotations that comes with it. But you see, when you look at nutrition in Ghana, there's a serious disconnect. We have a dual burden there as well. So we have a rising level of obesity and we have undernourished people. That is scary. That it tells you the gap between the haves and the have-nots. And I'll put the statistics out, and you'd see that our health system, as a result, is failing even the haves, but even more the have-nots. Because the haves think they are living affluently, so they are eating all the things they don't need to eat, and they are getting obese, and they are getting saddled with the non-communicable diseases. So let's look at the very vulnerable, because that is where I want to start from. According to the Ghana Statistical Service Democratic Health Survey, 18%, so 1 in 5 of children under 5 years, are stunted. That means they don't grow to their optimum level. 6% of them are wasted. Wasting means that you are actually losing the flesh you have on your body, and that is acute malnourishment. And 6% of Ghanaian children under 5 are wasted. And then when you look at it, 49% of these children under 5 from 6 months to 59 months are anemic. So if you take a child that is 5 years, on average, you take 2 children that are 5 years in Ghana, one of them is anemic. But the more serious thing is when you add, because 12% of Ghanaian children are also underweight, under 5 years are also underweight. If you add the stunted, the wasting, and the underweight, you get 46%. So there as well, 1 in 2 children are malnourished, and they are anemic as well. That's scary. Why is it scary? Because it affects their cognitive ability, it affects their immune system, and the what do you call it? World Bank has shown that, especially with stunted children, their earnings is 20% less over their lifetime than normal children. So if half of children under 5 that we have now are going to have some form of malnourished implications, you should see the economic implications. And as we go along with it, one thing I would want to point out is the losses we are making as a result of not correcting our health system, and how, if we corrected it, we could plow these losses back into the health system and actually make it better. So you look at it and you ask yourself, okay, maybe those are the poor ones. But then you find out that 10% of women between 15 and 49 years are obese, and 6% of men as well. So the ones who can afford are either overeating or eating the wrong things or not exercising properly and are not healthy. But majority of our children are also very unhealthy from a feeding standpoint. And I ask myself the basic thing, for example, after 8 years of planting for food and jobs and all these things, are these the statistics that we should be seeing? And this is why, Evans, we decided that we need to put this data out for the Ghanaian to make an assessment to see if our political parties, our governments are addressing our health needs.
Yeah, and that is a very important point. So what you're saying is when the manifestos come out, as you listen to us tonight, you would have to ask yourself when you look at it, Kwame, that the statistics that you're putting out there tonight, are they even paying attention to it? Are they addressing it? Because remember, our objective this year in running our coverage is inform the electorate. So if you're not seeing the points in there, then they are not addressing a very fundamental issue of importance to you. Let's go to another very important issue to you, but again, it is to everybody that must be addressed in any proper, responsive manifesto. And it's about sanitation. It's so important. What is sanitation? And Kwame, let me just put it in context. There was a candidate once in opposition who made it a priority in a manifesto and said to us with a target that he would make Accra the cleanest city in Africa. So then, if you were doing a health manifesto like this show, you would have said that candidate had ticked that box. That candidate we know has been in power for 7.5 years. We are nowhere near achieving that. You say this year we should assess these two parties on the same point of water and sanitation. Why is that still important?
Well, you see, availability of water is a fundamental human right. Even in war, one of the things you do and it's considered a war crime is to poison water. It's criminal to do that, even in war, when the other person is your opponent. So if you look at it and you realize that 36% of households in Ghana have access to potable drinking water, which means 64% don't.
That's a shocking statistic indeed.
Well, you see, and these are the things that worry me because these are data that our governments and opposition parties know. And that is why we decided that we were going to pick the data from Ghanaian documents. Documents that, you see, the irony is, Evans, these documents have been put together by organizations that are paid for with taxpayers' money. Yet the taxpayers don't know that only 36%, so 64% of households in Ghana don't have access to drinking water. The irony is that when you come to the urban areas, Accra, Kumasi, Takoradi, it goes to about 52%. When you go to the north, upper east, upper west, it drops to less than 25%.
It's even worse, yeah.
You understand me? Then 21% of households have access to improved sanitation facilities. What does that tell you? It tells you that 79% of households, so if you walk in the streets of Accra, Kumasi, 7 out of 10 people you would see who probably are very well dressed do not have access to adequate sanitation conditions. Yet they are going to vote. Why shouldn't that bother me? You understand me? And this is from the WHO and UNICEF. And that's why, for a lot of the data, we put the source out so that people can go and check. 18% of Ghanaians engage in open defecation. Open defecation, they ease themselves in public. Even cats are shy to ease themselves in public. But we humans, 1 out of 5 Ghanaians is doing that. So is it then surprising that 9% of deaths in Ghana are the result of diarrheal diseases in children? So 1 in 10 children who die in Ghana died because they had a form of diarrheal disease. And you know them, the choleras, the anemic dysentery type. 1 in 10 Ghanaians die out of that. And so you look at it and you're like, gee, someone told us that he was going to make Accra a cleaner city. If these are the statistics that we are churning out based on our own data, then there's an urgent need for investment in this area. But then when you go further and you see that there is also destruction of our water bodies because there's a conclave of, I don't know how to put it, but it's an ungodly alliance between an executive that cannot enforce the law, a security service that either is unwilling or unable to enforce the law and rid ourselves of the people destroying our water and river bodies. There's a citizenry who is recalcitrant because even though they know that this is going to affect them, they are engaging in the thing. And there's a media who's just, some are talking about it, but others, oh, it's the next big thing. And we're all sitting around. Meanwhile, poisoning water bodies is a war crime. Why wouldn't I want to know how this is going to be addressed as a health emergency in any political party manifesto?
Yeah.
And it's not just telling me I'm going to address Galamsey. I want you to show me how and show how it's costed. Because we live in an era with a poor fiscal space.
And again, this is so timely because we are talking about dengue fever outbreak right now. And fundamentally a factor of sanitation because the mosquitoes are bred in stagnant waters. If you clean the waters and you don't have it stagnant and the environment is clean, you're possibly not going to have the mosquitoes that spread dengue fever. And so that's very, very clear indeed. And so that then is a priority for any party drafting a manifesto, or should be. And we'll see if indeed they listen in these conversations we are having. And let's spare a few seconds very briefly to talk about tobacco. Because we rarely talk about smoking and tobacco, but you say it must be important. Why are you isolating this as part of your health manifesto?
I'm isolating it because, yes, we've done very well when it comes to smoking in Ghana by virtue of the Public Health Act. And the FDA also has been very, very upfront when it comes to ensuring that there's no mass medical advertisement. But what do we see now amongst the youth? You see all these shisha joints coming up and all these tobacco things having flavored and all that. And you realize that even though the prevalence rate is 5% in adults, they are telling us that 1 in 3 of our youth have tried these tobacco products, which means if we don't do something about it, it's going to get worse. And if you look at the economic burden, it's estimated by the American Cancer Society that it costs us $100 million because obviously we are getting the lung cancers, respiratory diseases and all that, and all these associated things due to tobacco smoking. And the other problem we have is that because of the strides we've made, it's become a hidden ill. So among the adults, they'll smoke privately rather than do it in public for you to see and counsel them about it. And so we need to get a bit intrusive. And I always go by this thing about Lee Kuan Yew. He said, look, Singapore wouldn't have gotten where they got into if he hadn't been intrusive. He says he's often accused of intruding into people's private life. But if you hadn't looked into how people live, who their neighbors are, how they speak, how they ease themselves, they wouldn't have gotten where they got to. So when you are looking at health, when you see these mushrooming coming, especially in the youth, you need to get pragmatic and act. And that is why we included it. We don't need it to become another problem.
Yeah, don't wait
We
for
need
it to become a big issue before you address it. And
Yes,
that's why,
because we are too reactionary.
yeah.
And I want us to be proactive, and that's why I added it.
Let's focus on something that we pretend to focus on, but it's still killing us in quite substantial numbers. And I'm talking about road traffic accidents. And you say it's actually a national health emergency. Why is that? The numbers are staggering, is it not?
Well, yes, because the National Road Safety Authority puts numbers out. And in 2022, for example, there were 2,500 fatalities. But they tell you that about 13,000 crashes happened in that same year. And often it takes away the breadwinner of the family. Apart from that, it causes unemployment because the people who get injured have to be taken care of. Sometimes the injuries they get are not even covered by the NHS. But more importantly, people have to take time off work to look after their neighbors.
Yeah.
So it is an economic drain. But the serious thing, Evans, is the fact that all you need to do is to go on a drive or on a walk. And suddenly, because of the carnage of our roads, if you are not careful, your life circumstances could be changed. And the truth of the matter is, you are, and everyone listening, has either been a victim, nearly been a victim, or knows a victim of what I'm talking about. But yet, we pay lip service to it. And we look at it, and you see, already the campaign has started, and then you see people showing roads that are being constructed and all that. And I tell myself, it's sacrilege that our main trunk road, Accra to Kumasi, is still single lane for majority of the times. Yet people are showing us roads. And I'm like, are you addressing this as a public health concern? Or you're just doing it because you want people to vote for you because you constructed a road? Do you understand the health implications of poor roads? So I want to see in manifestos, and that is why I've done it as a crosshairs. So yes, this would come under your roads and all that, but you need to demonstrate how it would address the health concerns and how you are costing it. Not to be constructing roads 6 months to an election and expect us to be voting for it.
And in terms of measurable interventions, now you have 2,500 fatalities. Should we expect in the manifestos intervention spelled out that says by 2026, I want to have this to 1,500 very clearly?
Yes, a manifesto should contain smart objectives.
Yeah.
So they should be measurable, they should be achievable, they should be realistic, and they should be time related.
Yeah.
So if I don't see that in a manifesto, the manifesto is not smart.
Okay.
And we need to move away from a manifesto that just comes to gaslight us.
Yeah.
Because it's no longer about getting our votes. It's about addressing our health needs.
And that's important. And we quickly, as we wrap up, I want to focus on something that is big, but we don't focus on it a bit in this country. Preventive care. We always wait for us to fall sick before we rush to the hospital. We rarely go to the hospital for checkups. I mean, can a manifesto even deal with that? Should it even attempt to tackle it? You said it should.
Yes, it has to. Because the essence of governance, health is a public service good. The essence of any government is to keep the citizens as healthy as possible for as long as possible, and to prevent them from going into secondary, tertiary, and quaternary care, because then you'll become reactionary. How do you keep them healthy for as long as possible? Is by identifying the chronic diseases before they become a disease state or an epidemic or a pandemic. How do you do that? You do that by proactively screening your citizens to identify them so you can manage them on lower tariffs. It helps your national health insurance system. It helps the people, because as you go along, you go to health finance, you see that we actually pay more out of pocket to keep ourselves healthy. So if we are not addressing this and they are not telling us, like for example, in 2020, the NDC manifesto was talking about free primary health care. Then people were saying it's not doable. Today, The NHIS is telling us that their priority has to be preventative care because that is the only way they would be able to secure their budget and make their scheme sustainable. Meanwhile, 4 years ago, the MPP were telling us it wasn't doable. These are the things I look at and I'm like, why are you trying to play ball games with us? And so preventative care should be a priority. In countries where the health systems are sustainable, preventative care and primary care has been the main driver of the health systems. And we need to see that in our manifestos. Again, costed with smart objectives, not just I'll do preventative care or I'll do free primary health care. Show us how, show us the money you're going to put into it, how are we going to measure it, and how are the citizens going to judge you by it. That's what I want to see.
And as we go through this, and shortly in the next few minutes, we'll be sitting down and expanding on this a bit more. Note, the importance of this is to say when the manifestos come, want to measure, as far as the health sector is concerned, measure what you're trying to tell us as against what should be the case, what the priority should be. Another one is maternal and child health. And as a country, Kwame, we've struggled to sustainably tackle this problem of maternal and child mortality. What is the current picture? And what commitments do you propose political parties must take to deal with this?
You see, Evans, the humanity of every society globally, is how it treats its most vulnerable. So when it comes to health, you are looking at the very young, those who bring us life because they guarantee our population growth, which then guarantees our productive economic base, and the elderly. So if you look and you realize that infant mortality is about 28 in 1,000. Out of every 1,000 lives there, 28 would die. That's too much. And the 5 mortality, out of every 1,000 lives there, 40 would die. Why? And you see, you look at our own data and it says only 47% of health facilities offer outpatient management of severe acute malnutrition. One of the reasons why the children are dying, we already looked at malnutrition, is malnutrition. Less than 50% of our health facilities offer this to the children. Why have we allowed this to happen? Is this being addressed by political parties? And 54% of health facilities have a child and infant weighing scale. 46% can't even weigh your children. Why? Yeah. And these are the ones who guarantee the longevity of our population. So I want to see how these things would be addressed.
And Kwame, on that point, I want to go to 2 big issues, and then we can sit and expand on the others. And there are other key areas too, but 2 big issues before we wrap up and expand for the next hour or so, which is one, infrastructure problem that you believe must be big, and then we'll also then end by talking about the health insurance. But let's talk about infrastructure, health, and I want to put 2 together here. So the health financing and then health infrastructure. Governments have attempted to build this pool infrastructure there, but it's not linked to dealing with the doctor to patient ratio, for example, because if you expand the infrastructure, then you need to have doctors in there to manage. Why are these 2 issues very important that must be addressed in the Health Manifesto?
Well, you've hit it right on the head. Without doctors, health professionals, nurses, pharmacists, you cannot open up a hospital. And in this era of technology, the question we need to ask ourselves, especially when our health harmonization assessment report is saying that 95% of our health facilities do not have the full complement of diagnostic equipment in consultation rooms to diagnose you. Only 5% have. So do we need to be building more brick and mortar when we don't have the health human resources to man them? Because you end up with a no-bed syndrome situation. So that's the first thing. The second thing is, are we looking at the data that the Ghana Statistical Service is turning out in the Demographic and Health Survey? Are we looking at the health harmonization data? Are we looking at the holistic assessment of the health Ghana Ministry of Health Program of Works data? If we were, what were citizens doing when someone came to tell us he was going to build 111 hospitals? Did we not know the number of doctors we had? Did we not know that from August last year to now, over 6,000 of our nurses and midwives have left to go and practice elsewhere? You see, so you ask ourselves, are we doing this because we want votes? Because some chief somewhere, a politician went there and he said, I want a hospital, so we'll give you one. But if we did a needs assessment of the requirements of that health needs assessment of that paramount, is it a hospital they need to address their health issues? So I want to understand, if you tell me you're going to build a new hospital, what is the statistical data backing it? Where are you going to find the money from? And more importantly, how does that address the need? But in that, what do you call it? Auditor General's report tells us that with health sunk costs, infrastructure that we've started and we've been completed, we are losing 1.3 billion Ghana cedis. Are you going to complete that first? So these are the things I am looking at, and I'm like, no, this year, if you don't address this, then you don't want to have a health conversation. And I believe that as Ghanaians, we should be measuring the health manifestos that they put out against some of these things.
And let's end, Kwame, on that big subject we've been talking about last year and this year. Especially, it brought the dialysis crisis conversation brought the national health insurance into some sharp focus. And it was just in this studio that the chief executive was with me. We're talking about it. And he talked about the funding challenges they have. And one of the proposals he's making is that uncap it, but also don't put the monies coming into the national health insurance scheme into the consolidated fund. And it's a proposal that he was pushing on PM Express. What do we do with the national health insurance scheme? And what should a responsive manifesto do with it?
Well, a responsive manifesto should be telling us how it's going to ensure that, for example, hospitals, pharmacies, and all providers are paid on time. Because the problem is, if you lock up their capital, you are collapsing their business and you are creating unemployment. The other thing is, it then increases the out-of-pocket payments that the Ghanaian is paying. Already, 50%, 48.5 actually, but 50% approximately, of all our health expenditure per capita comes from out-of-pocket expenditure. The government pays just around 30%, and our development partners pay the rest. So even though our health expenditure per capita has gone to $100, you are paying $50 out of it from your pocket. Meanwhile, we have a health insurance scheme. Why? Because someone in his wisdom cut the scheme and said, I have more sense than the act, and I know why we can use the money properly. And less money is going into the National Health Insurance Scheme. So I want to understand how you're going to change this. I want to understand, for example, the premiums that are being paid, because their funding stream is a bit amorphous with these premiums that are being paid by others, like people who are working and all that. Can we scrap it? Because it's become an affront to health access. And if we scrap it, how are we going to get those funds for them? I want that addressed. Because the National Health Insurance Scheme currently covers about 70% of the population, which means 30% of the population are not covered. That is unviable because it's an affront to universal health coverage, which says that finance should not be a barrier at the point of use of healthcare. So I want clearly people to be telling me, I'm going to ring fence this money as per the act. I'm going to have maybe a fund for the National Health Insurance Scheme with their own fund managers like Snit has and all those people. And they are going to make their informed decisions on how to invest these monies. They can even decide to invest it in roads and toll them and other things so it brings them more revenue and use some to pay. That's out to their fund managers and make this viable. So I don't want, it's now covering 70%. It's now covering 70%. What's the proportion of active users? And that is why I am highlighting the National Health Insurance Scheme, because without it, we would not achieve universal health coverage. And one thing we have to realize is universal health coverage, we signed up to achieve it in 2030. We are voting in 2024. The next government will take office in 2025. We have only 5 years to achieve it. So if serious, smart objectives are not in some of these manifestos, to address the challenges that make finance a barrier, then we are joking. And that is, for me, the biggest thing for the National Health Insurance Scheme.
And Kwame, thank you very much. Kwame is going to stay with us. My guest will join me now. We're going to be joined right now by the Ghana Registered Nurses Midwives Association. We'll be joined by the Ghana Medical Association will join us. The Vice President is here with me. We'll also be joined as we have this conversation with the Ghana Pharmaceutical Society, unpacking this a bit more. What are their own expectations? It is important, right? If the parties finish their manifestos, if you wait and they put it out, the health sector, they will stick to what they put in a manifesto. If you have to find a way to influence it, let's get the conversations going. They work in the sector. What do they want to see? My panelists are weighing in after this. So we've been through the first part where we've heard from Kwame Sapon-Sadu laying out for us what the health manifesto should focus on. My guest now joining me in the studio to unpack that a bit more. Kwabena Asante-Ofer is the Vice President of the Pharmaceutical Society of Ghana, is with me in the studio. Also with me is Professor Ernest York. He's the Vice President of the Ghana Medical Association. He joins us on Zoom. Dr. David Tinkran-Chum is the General Secretary of the Ghana Registered Nurses and Midwives Association. Of course, Kwame Sapon-Sadu is still with us on Zoom, and we'll hear from him as we discuss this a bit more. But I want to start with you, Dr. Tinkran, on this part. And I want to start by sort of getting your own views on, for nurses and midwives in this country, we had the detailed issues that Kwame put out. What are the key issues for you that you want to see the manifestos address?
All right. Good evening to you. Good evening to my brother and Dr. York on the call and your viewers. Of course. I mean, I listened to Kwame and that I'm really impressed about what I saw and what I read. I got the opportunity of reading through aspects of his studies before coming to the studios, and I think that he has unpacked the issues. Now, coming specifically to nurses and midwives, I mean, if you look at the Ghana Democratic Health Survey 2022, the things that they've put out there, it boils down on those who are actually taking care of the people. If you are talking about malnutrition, if you are talking about mortality, maternal mortality and all that, there are people who are providing those services. So what we did as part of our strategic engagements with government and, of course, with various opposition parties is that we had opportunity in 2020 of meeting Mr. Mahama. We gave a position paper on most of the health needs of our people. And likely, recently we met the NDC Manifesto team, Manifesto team, and we have given them broad areas of concern that we think that if they pay attention to.
Bullet it for me. What were those issues?
All right, so we looked at, if you like, education and research as far as nursing and midwifery is concerned. And we felt that research is abound with how baccalaureates, highly trained nurses and midwives, has the propensity of reducing mortality. 10% increase in baccalaureate education of nursing is able to reduce mortality by 10.9%.
What's the current picture?
The current picture is bizarre. In Ghana, nursing is the only profession in Ghana that we have 3 levels of entry. Okay, almost 60% of our nursing workforce are auxiliary, and we think that that's not the way to go. We think that majority must be degree prepared. So we have to cancel certificate programs, we have to cancel diploma programs, and train nurses and midwives at a degree level.
That's bold.
Precisely.
Cancel certificate programs, cancel diploma programs, and just do Bachelor of Arts.
Bachelor of Nursing degrees. Exactly.
Bachelor of Nursing, sorry.
Yes,
Bachelor of Nursing degrees, and then you do the Masters and onwards.
Precisely.
That's bold.
Yes, it's a bold decision, and we need to do that. When you go to next door Nigeria, anybody practicing as a registered nurse or midwife has a first degree. That's where it starts.
Nigeria is doing
Precisely. And we could do better than them. All right. We have the human resource, we have the schools that can do that.
And please help me appreciate, as we speak, and this is brief, because now that you've narrowed down, I like the numbers, because that it helps you picture it. Right. What's the share in terms of the nurses you currently have coming out into the health field? What's the share you get from those from certificate and diploma and those who are coming in?
Okay, currently the diplomas account for about, the diploma, or if you like, the auxiliary nurses,
yes.
Okay, account for about 60%.
60?
Precisely. And then the professional nurses account about 40%.
So what
in
images?
Ghana, the diploma level trained and the degree level trained nurses and midwives are professional nurses. But what we think is that if we're able to prepare them at the baccalaureate level, it will help. All these maternal indicators that we are seeking to, talk about, and we want improvement in maternal health and all that, premises on that, because as I alluded earlier on, research is abound, okay, on how highly skilled, prepared nursing workforce or midwifery workforce.
So what you're suggesting, for example, that 60%, if you cancel certificate and diploma, what happens to them?
Okay, so if we cancel the training of diploma and certificate, we can upgrade the knowledge of those who are here. And they are actually doing that. We have access calls that is churning out, or if you like, upgrading the knowledge of those in certificate, diploma to degree preparedness and midwife. So that can be done. So they will not be abandoned in that order. Previously, you had to do other things. Either you go back to better your grades and stuff like that before you can even improve. But now there is an access course, a break course that helps you to be able to upgrade your knowledge and skill to get to the degree.
But what it also means is that the number of nurses you're training now will significantly be reduced.
No, it's not about producing, it's about retention. You see, I said earlier on that we think that we have to train and train and train. To me, it doesn't make sense. What makes sense is how to be able to retain the few that you have trained, okay? Because if they have very poor working conditions, they will leave. And look, it's not about those who are leaving are the creme de la creme. For instance, they work for 5 years, they work for 10 years, they've built certain competencies and proficiency, and they leave. If you replace them with numbers, it will not satisfy the demands. Because see, health outcomes, if you want to improve health outcomes and things like that, you need people who are highly educated, who are highly proficient on what they do. If the person stays on the job for 5 years, 10 years, gains certain proficiency, certain competences, all right? Of course, you obtain the requisite knowledge from school, but you build your competences as you stay on the job for a while. When such people leave and you replace them quantitatively, you are not doing any good to the health sector. All right, so that is the position in terms of education and research. We think that we should be able to intensify research among nurses and midwives, and that is the way to go.
And secondly, briefly, because I don't want to bring in a
precisely. And I also talked about, for instance, if you want to train them at that level, then there is the need to also establish a college of nursing and midwifery, which is here now, but we don't have any edifice to that effect, all right? They are in rented premises and stuff like that. So when we met Mr. Mahama and his colleagues and the other people in government, we made it clear to them that as President Kufuor built College of Surgeons and Physicians, edifice that you see over there, they should be able to do the same for nursing and midwifery, so that we can have state-of-the-art edifice that will be able to churn out specialist nurses and midwives in Ghana to be able to improve the health outcome.
Fascinating stuff indeed. And I will come back to what reactions you got when you met them. Were they receptive, and did they make promises and commitment that they're going to put that into writing? Mr. Fuller, I'll come back to you pretty shortly, but let me bring in Dr. York, who joins us with the Vice President of the Ghana Medical Association. Prof, grateful that you could join us on Zoom. I've heard a lot of things today that makes me really now looking forward to the manifestos to see, are they addressing these issues in their health manifesto? For the doctors, though, what are the big issues for you?
Well, good evening to your listeners. Evans, can you hear me?
Loud and clear, yes.
Great. So, good evening again, once again to your viewers. So we have met the political parties as well, both parties. I'm talking about NDC and NPP. And we have, make known to them exactly what the doctors want. But let me quickly go back and talk about, the pillars that we make known to them.
Yeah.
And you see, the ethos of what we said was that we want to see a linkage of the promises to the goals. I just perused the manifestos of the two big parties before this program, and it's all about I will do. A few of them, one or two attempt to, suggest why they want to do, but in the end, or overall, it's about just bullet points. But how does it link to health statistics? How does it link to outcome? And that's what we're looking for. Not just mere promises. Like as Kwame said, the measurable outputs that we can hold them to. So in broad areas, what we suggested to them was that one key, was to improve the healthcare financing, production and retention of quality of professionals. We're also talking about equitable distribution, strengthening universal health coverage and primary health care. And again, the issue about non-communicable diseases came up in our discussions. The issue of cancers, renal failure, and all that is one of the things that we hope they will address head on. Emergency preparedness, pandemic preparedness, improving the health statistics, and our focus to them, and we known to them that we want to focus on maternal and child health. In the end, that is what drives and improves the health indices, And screening, you can pour, the water. If it's in a basket, it will leak. But if it's in a bowl, it will stay. So what we are saying is that prevent it. Don't just let's pour resources into activities, but let's prevent the disease from becoming manifest anyway. The last but one was mental health strengthening, and then intersectoral collaboration. Kwame mentioned about sanitation and, road traffic accident linking to it, and it's absolutely true. It may not be a core health issue, but if that is the aim, we can liaise with Ministry of Sanitation, local government, and say that we want to improve health outcomes, and therefore, we need to collaborate to achieve this aim. But let me touch quickly on one thing that, the health financing issue. That is the primus. The strategies will be there, but it is important. And I'm going to be controversial before I end. Kwame talked about, the consequences or the effects of the delayed releases in tariffs, the monies that they owe the health institution, including the pharmacy outlets and all that. And that is driving out of pocket payments and substandard care. But we are saying that the issue of capping of the collected funds for National Health Insurance Scheme and Authority must stop. And we want genuine commitment from all these parties to say that when we can, we will remove the capping and decap them. Because, you see, even the amount that is decapped is not released in timely manner or terminals. Now, the decapping amount is a lot. That could improve these health indices that we're describing. So we want firm commitment from all the parties that when they come to power or we entrust the mandate of this country into their hands, they are going to remove this. And I will urge all my colleagues on this platform this night, the nurses, the pharmacists, and everybody involved in healthcare, let's all come together and demand that the decapping of the collections of the national. My last point on this matter, Evans, before you come.
Yeah, no,
yes.
No, go on.
Okay, all right, great. I'm going to be controversial, is to suggest that the NHIA must be decoupled from the NHIS. And why do I say that? So they become a judge, a jury, and a prosecutor in their own court. So they set the standards, and then there are players in the same vein. So who is going to tell who that release the funds that we collected? So that we have within the insurance space, there's an insurance commission that's a regulator. There's the national MPRA that's a regulator in the pension space. So when you are misbehaving, they can tell SNCC to hold on, with your intended divestiture. That is what we want in NHIA. So there has been an authority that's a regulator sitting at the top, emanating policies and programs and making sure that the players, which will now include the National Health Insurance Scheme, would also be regulated and they will be more accountable.
Okay. And these are very powerful points indeed that all of you are putting before the manifesto committees of the parties. They have their work cut out for them. We haven't even heard from the Pharmaceutical Society of Ghana. Have you met the parties already, Dr. Ofori?
Yes, we have a fair. We have met both the NDC. We met the former President Mahama. We've met also the Vice President, Baumia. And before that, we had met their manifesto teams. But before I tell you what we discussed there, just also thank Kwame for that brilliant presentation. Yeah. And proud to say that he's also a pharmacist, so I'm not surprised about that at all. And then also to make the second point that I think that in this election, the Pharmaceutical Society of Ghana believes that this election, if health would be the center point of the debate, I think that will go along with health. So
you want health to be the center point?
There are sometimes that in some elections it's education, sometimes it's infrastructure. But I think that there should be a time that health should dominate. We should get to a point where we say that in these 8 years, we are going to deal conclusively with healthcare as it relates to the people.
This is the way the free SHS became the preeminent policy, and everybody
exactly.
was campaigning on
exactly.
it. You want that to be.
And to that point, in the coming annual general meeting of pharmacists, on the first arrival night, we are dedicating it to bringing all the political parties together to discuss healthcare, because that will be getting to the point of the elections, and we want to make sure that health does not die as we get towards the election point. Now, to the points that we've been discussing with them. The first point, I want to join my colleagues regarding the health insurance. We have been advocating for a long time now on this decoupling, on making sure that the funds for the health insurance comes to them in full. Because the point of the insurance was that people who perhaps, excuse me to say, who may not have even the little resources to be able to access healthcare because of health insurance will be able to have healthcare. But then because of the capping, there's limited resources to the NHIA. And sometimes people go to the facilities and they say, well, health insurance covers this, but we are not able to give it to you under health insurance because they haven't paid, or they don't have the money, or they don't have the commodities there to give to people. And the people who suffer the most under these circumstances are the people who are also the most vulnerable or the most under-resourced. And so I also want to support the position that my brothers have talked about, that NHIS monies should be given to NHIA in full. The necessary measures should be put in place to make sure that the expenditures on there are made efficiently and they are not misused.
Kwame proposes in his health manifesto that money shouldn't go to
the consolidated fund. Yeah, I agree.
It's a deep black hole. Once it enters there, disappears, struggles to come out. Although the law says what should go to it, it doesn't come on to the go and fight for it.
Yes. So I also agree with that. I agree with that. And I think that we should, because these are constitutional matters and all that, and it's going to take a whole long process for us to get that. But we need to, have some sort of a roadmap that ultimately will decouple it from the consolidated fund. But if the Constitution requires that the money goes to the consolidated fund, let's go into the consolidated. But we should know exactly what is going to the consolidated fund, and there should be no limitation on that money coming to the NHIA for the work that has to be done. Okay. So that is the most important thing. Whether it goes or it doesn't go, at the end of the day, the money, all of it, should come to the NHIA for the work and the purpose for which the NHIA was set up to do. So that's the first point. The second point, Evans, is that when I was in pharmacy school, there was only one pharmacy school in Ghana, which was KNUST Pharmacy School. We were producing averagely about, let's say, between 80 to 100 pharmacists every year. So for a long time, and that was when my batch, so previous batches were producing maybe 20, 50. So for a long time, pharmacists were under 700, 800. Today, they are about 8 or so, or 9 now. I've seen now one more has been registered, pharmacy schools in Ghana, producing close to 800 or so pharmacists every year. That's the point number one. The second point is that pharmacy education used to be 4 years. Now, my colleague is talking about changing the qualification. Now, pharmacy education is 6 years. What is different about it is that there is more emphasis on clinical education. And so pharmacists, in terms of clinical expertise now, under the Doctor of Pharmacy program, are more equipped, better quality pharmacists in terms of their training than the Bachelor of Pharmacy program. So there's a greater number of pharmacists, there are better quality pharmacists today. And then lastly, pharmacies, when I looked at the last data, there are about close to 5,000 pharmacies across the country. And pharmacies are also located in our communities. People see the pharmacy as when there's something happening, they want to go there the first time.
I mean, and then just by way of education for people, what makes it a pharmacy?
So it makes it, okay.
Because this is bottom, right? Because it's abused sometimes.
Yeah.
Everybody builds something, puts some drugs in it, and it's a pharmacy.
Yeah.
Right? Those watching us tonight who are not in your field, what makes the pharmacy?
Thank you.
Is it because the human beings in it who are qualified pharmacists, or the building with the name and drugs in it?
Okay, well, it's a bit of both.
Okay.
So a pharmacy...
And it's a very brief, just for public education.
A pharmacy, so there are pharmacies, and then there are over-the-counter medicine...
drugstores.
Or chemical shops.
Chemical shops,
yeah.
okay.
So pharmacies are those which have a pharmacist there, a licensed pharmacist present. So the licensing of that business or operation is giving us a pharmacy because there's a pharmacist who is under law to be there all the time to buy pharmaceutical services. And because of that, all medicines have been classified by the regulator, Food and Drugs Authority, into 3 classes, A, B, and C. And pharmacies have all classes of medicines because there's a pharmacist on there. Now, licensed chemical sellers only stock class C medicines, and pharmacists are not there. So they are over-the-counter medicines like, some multivitamins and some medicines for pain and things like that. So you don't have class B and class A medicines. And those are to be set up in places where there aren't pharmaceutical services yet. So they are more remote. And they're about, interestingly, there are about 19,000 over-the-counter medicine sellers there. And we have a proposal on that to the politicians.
So your big point there was, just go back to your original point.
So our original point was that we have all these great number of pharmacists who are of better quality now, and there's this spread of pharmacists across the country. How are we integrating this quality and number of pharmacists and the spread of pharmacies into the mainstream healthcare delivery? When Kwame was talking, he talked about, for example, non-communicable diseases. And my brother from GMA talked about
the Vice President, Dr.
proactive screening and identification of cases. So people don't go to a health facility until they have some sort of deformity or some pain. So somebody can be walking around with high blood pressure or high glucose, and there's no symptom yet because there's no complication. But we have to be proactively looking out for these people. One way that we can do that is to be able to ensure that we integrate pharmacies with pharmacists in there into the health system, such that anybody who comes to a pharmacy would have either a blood pressure check or, depending on the risk profile of the person, a blood glucose check. And because of that, we can proactively identify these people and then link them up or refer them to the health system where they can manage their conditions. So that's number one. Number two also is that should every health condition be taken to a hospital, for example?
For Dr. Tinkran or for York?
Exactly. Where are there some conditions that, based on now the training of pharmacists and the availability and the proximity of pharmacist communities, we can say that this scope of conditions will manage them at the community pharmacy level. And this is not something that is novel. In some other countries like the UK and other places, there are specific conditions that are managed at pharmacy level to decongest the health system, so that people who actually need that health professional will then have access to the person and not go to the facility and wait for several hours just to see the professional, because other people whose conditions could have been managed at the pharmacy by these health professionals could have been managed. So our number one proposal to the political parties has been the integration of pharmacies into the primary healthcare system.
And very briefly, how are you proposing to do that?
So first of all, the Ghana Health Service has recently launched what they call the networks of practice. The networks of practice is that in every community there's a health center. So that health center is going to be upgraded into a model health center. And all other health facilities, smaller health facilities in that area will be linked to that health center. And that health center is supposed to provide technical support and then operational support to these facilities. So pharmacies in those areas, the pharmacies should be included in the networks of practice and be formally linked to that system, so that when somebody comes to the facility and is screened and there's a need to refer straight away to the health center. That's number one. Number two is that all the pharmacies should be linked up in a digital system.
Okay.
You understand? Because in non-communicable disease, you also want to be able to longitudinally manage your patients. So it's not just a one-time touch and go. Yeah. So this person comes to the pharmacy today, checks a BP, and it's a certain amount, goes to the hospital, is on a medication or whatever it is. But periodically, you can come to the pharmacy and then check their blood pressure again to see where they are in all those times that the blood pressure is being checked. There should be a system where that record becomes available to the health facility, so that when he finally goes to see a doctor, it is not just the time that he's seeing the doctor that he's seeing the blood pressure, but all the times that he has gone to check the blood pressure at various other places.
I listen to all of you, and the goodness, this manifesto that you guys are pitching to the parties, we really be rich if indeed they take your advice on the issues. And I know the other issues that you have, but because of time, I want to go around a bit more.
Just a quick one then.
Quick one, okay.
Another thing that we think is a huge advantage to our country is the issue of local pharmaceutical manufacturing. And that's the second point we have been making.
Okay, briefly, because that is important. Yeah. What is the proposal there to the parties?
That we should target that by the time the term is over, we have X number of local...
Don't say X. Manifestos. Kwame has admonished us. Yeah. It needs to be measurable.
Yes, it has to be.
So what is it that you propose to them?
So we have two proposals on that. One, we have 5 local pharmaceutical manufacturing facilities that have the capability to manufacture, I don't know how to put it, medicines that can be used for HIV and AIDS, malaria, and tuberculosis. Because you see, so you're saying, the bedding...
Just let's clarify, you're saying that you already have, or you're saying that whichever party wins must have a manifesto that says, I'll deliver on at least 5
yes.
institutions that can manufacture this.
Yes.
By the end of your 4 years.
Yes.
Okay. That's what you're demanding from them.
And this is the context of that. As Kwame was presenting, about 90% of malaria bedding is in Africa. 75% of HIV bedding is in Africa. But where are we getting the medicines to treat these medicines from? The Global Fund purchases these medicines. Where do they purchase it from? They don't purchase from Ghana or Nigeria. They purchase from factories that are outside of the country because they have to meet a certain criteria. Now, that is the whole conversation. Can we have 5 of our companies supported to be able to elevate their manufacturing to that level where they will qualify to get a contract from Global Fund?
So they can manufacture it here.
And then make it available to people in the sub-Saharan Africa.
That makes sense indeed. Yeah. Gentlemen, I want to end on expanding on health financing. Because everything else you've said comes down to financing. If the money ends there, you're not getting your 5 factories,
yes.
A pharmaceutical factory, you're not getting it. You're not getting the college you're looking for, and the doctors aren't getting what they want in terms of the capping. The capping is there because government is sometimes broke, and so they capping it to do other things. So let's address that. Before I come, there's a very controversial point, just in 2 minutes, I need to get you in there before I come to that, which is the nursing training allowance.
Okay.
Right, which was a controversial one before. Where are you on that? Another election cycle is here. Are you saying they should maintain it or they should scrap it?
No, it ought to be maintained. People don't understand. It's not just money being doled out to student nurses, all right? A study was carried out in 2014, and we found out that 40% of nursing services that are rendered in our various health facilities are performed by student nurses. So it's a form of compensation for what they do. So, I mean, it was cancelled and later it was replaced, but we are having difficulties of payment, not only allowances, especially those who are doing rotations. As I speak to you, I think they've done 11 months, they've not been paid and all that. But let me come back to the health finances. Extremely important.
No, so let's come there because I think you've addressed the point. So maintain it is the point.
Maintain it is the point.
I know NDC says they're not going to do it. MPP says they're doing it. But you say both parties maintain it. Whoever wins, maintain it.
It ought to be maintained because it's not just an allowance being given to nurses. But
let's go to health financing. What are you proposing from the Ghana Rights and Nurses?
Precisely. It's whatever they have said finds expression with whatever conversation we had with the various political parties. But we want to go beyond that. We think that we need to set aside at least 2% or more of the oil revenue into the National Health Insurance Scheme.
Okay.
All right?
That's another radical one.
Precisely. You should have to take bold and decisive decisions when it comes to the health sector. All right? Let's look at the Alma Mater Declaration in 1978, where all countries, about 134 countries that met, decided about 16% of a country's GDP should be directed towards health. Have we achieved that? Abuja Declaration, ECOWAS leaders met and they said, they can commit 15% of their revenue into health. Where are we? Ghana, we're doing something like 9.5% or 10%. We are nowhere there. I had an opportunity of working with National Health Insurance.
Kwame, I'll come to you. I know there's something you address in your health manifesto. I'll come to you briefly, and then we can get the others.
So Kwame talked about reinvesting a certain form of financing, and precisely I agree with him. I think that we have to take very calculative and bold decisions in providing financing to the health sector. And we are proposing that at least between 2 to 5% of our oil revenue should be directed towards health. I
see. Kwame, you say that currently we are underperforming in terms of the percentage of the GDP that we are putting into health. I think 4% you say, when the WHO has at least 5%. What is your proposal for all the parties in a responsive health manifesto?
Okay, thanks, Evans. You see, we need to be bold. And if you look at the Abuja Declaration, it's not undoable. Currently, Rwanda, which has moved from the basket case of health systems in Africa 20 years ago, has moved to number 8 in Africa. What did they do? They committed 20% year on year of their government spend into health just by doing that and managing it with smart objectives. And now, what did they do? They shifted their life expectancy from 41.3 years to 69 years, overtaking Ghana. At the time when we signed the Abuja Declaration in 2001, they were not even signatories to the document. But what has Ghana done? We still, my colleague was talking about 9%. That is being very charitable. We are at 4% of our GDP.
Depends on the figures.
The WHO says 5%. We are at 4%. Why did Africa go, ECOWAS go to 15%? Because we had to play catch up. But to play catch up, we are now backing the trend at 4%. That means our politicians are not serious. And that is why when I have to have this conversation, I say, let's park the technocrats. Because they are implementers. It is the money you give them that they are going to use to resource the health systems and design it. We lack the political will to be ambitious. So a lot of the things we are talking about, whether it comes to pharmaceutical manufacturing, whether it comes to nursing colleges, whether it comes to what my friend and colleague Prof. York said around all the beautiful things that can happen about being bold with the National Health Insurance Scheme, is down to political will. Look,
and Kwame,
let me land on this.
Before that, what percent of our GDP are you proposing the manifestos must commit to?
We need to, at a minimum, be doing the Abuja Declaration. We signed it.
Which is 15%.
It was signed by. Look, you know the irony of our politics. The Abuja Declaration was signed in 2001 by President Kufuor. Sure. The worst government that has disabused our approach to the Abuja Declaration has been an Akufo-Addo's government since 2017. How does that make sense? The people who committed us to the declaration are the worst defaulters. It's not like the NDC were any closer, but I'm trying to say, if you have your president sign it, then you would be more
committed to it.
What you call committed. The same thing when it comes to health migration. The FPP signed the Kampala Declaration in 2008. The review was held in Ghana in 2009 when the NDC are taking over. The two political parties who committed Ghana to it have all defaulted. So you see, and that was why I said it's very important I land on this. The National Health Insurance Scheme, Prof. York was saying, oh, he's being bold. No. I disagree with you, Prof, on this occasion. You are not being bold. You need to tell them they are breaking the law. Let's go read the act. You collect money that is in an act of parliament to say, we are going to use for this, and use subsidiary legislation and FI to say, no, I'm going to cap it. They are breaking the law. And I hold the opinion that all those monies that have been taken since 2017 are loans. They are part of our public debt because they have to be paid back to the NHIS. And we need to be bold as health professionals to go claim that money back.
Let me bring.
They cannot take that money.
Let me bring in Professor York into the comment. Prof, health financing. Nurses say at least 2% taking from our oil revenues put in there. Kwame Sapansedu says 15% of GDP devoted to, at least that, devoted to the health sector. What do you say, and where should that money come from? I guess is most important.
Hi, thank you, Evans. Kwame, so what I meant when I was speaking about boldness was respect to decoupling the service from the authority, really. But I think you're right, and in asserting that it looks like some, provisions of the act is being broken. But Evans, back to your question about where the monies will come from, financing. For me, I think we should learn to walk from 1 to 2, crawl before we walk. A lot of monies are being held back by the decapping scheme. And so until we do that, for me, going forward will become pointless because it is huge, man. Correct me, Kwame. It's probably about 30 or 40%. You know, that is huge. And even the amount that is left after the decaping is not being released.
No, what did you say, Prof? It's not 40%.
How much is it?
87.5%.
Decap.
The initial cap was 75%. 25% was going to the NHIs. We didn't react. And that is one of the things that upsets me most. Because in 2017, immediately Ken Oforiatta announced that I raised arms. From CDD, we raised serious arms and said, this is the beginning of the collapse of our health system. Okay. But because we didn't react, they then took it to 87.5%. Right. Only 17.5% goes to the NHIs. And of that, in 2022, they paid 6.1%. It's in the Parliamentary Hansard. Anyone can go and check it.
So, Evans, you see what we are talking about. That is why all they talk about bringing oil money into it. Well, it may be nice, but until that humongous amount is removed or decapped, we are not going nowhere. So for me, that is where I'll stand. That is where I'll say today, tomorrow, and any other day. That should be the first step. So once we get the full realization of the actual amount, and then we can know where else can we get money to shore up. But Evans, quickly, when we met the politicians, the parties, a few other things that we talked about. We talked about staff retention and equitable distribution. But let me just start on one point about, rural area incentive allowance. It's a policy document that all the stakeholders came together to develop. It's gathering that at the ministry. Because you see, I can sit in Accra and watch my DSCB, which I cannot do that, in the rural area. I can sit here, my kids will go to the best schools, probably not the same elsewhere. So there has to be some differential incentive to drive people to the rural areas and then keep them there. We have developed this policy and it's gathering that. So again, we are saying that we want firm commitment by these parties to make sure that when they come, they will implement it. And it's one of the things that, we will hold them to. Now, this one is my proposal. And let me say it. It's about tax holidays for individuals and entities that set up in the rural areas. Let's again give them tax holidays, like we do with foreign companies and those in the mining sector, and also those in the free zones. Again, that would drive, human expertise to drive better healthcare, to these deprived areas to ensure that we can expand on the universal health coverage that we see.
And what are you proposing to the parties to do about brain drain? All the doctors looking to run away to UK and the US. What's your proposal to the parties?
Yeah, I'm a teacher, and I tell you, almost every week I'm signing, endorsing testimonials for people to travel outside. And it scares me. It's not just the young doctors, people who are specialists are also leaving. So, I mean, it cuts across the doctor, fraternity. It's also about all health workers. The fundamental question remains that the remuneration is poor, conditions of service is bad. Now, in dollar terms, I can tell you that what we take home has plummeted by more than 300% over the last few years. So
how much is the average doctor taking now?
Who?
An average doctor?
It's about $500 equivalent. So you can imagine, and you probably thought that it would be in the thousands of dollars. That is not so. So so people are weeping, they are dissatisfied, poor infrastructure, so they are packing bag and baggage. So that must be reversed.
And so what's a specific proposal to the parties? So what are you holding them to?
Remunerations and tie it to economic indices. Not just say that we've increased your salary by 100 cedis. But what is the real value, not just the nominal value of the increment that you've done? How is it going to ensure that people get satisfied with what they've been given? And then it can take them home and take care of their families and their personal development. That is what we want to see, that commitment from these parties. Lastly, before you let the others come in, one of the things to highlight on the LCDs, it's about identifying the main drivers for us, that is hypertension and diabetes, early detection, early treatment and management of complications. The renal dialysis issue, we proposed to them that they should set up a fund. NHIS recently released earmarked some money for that. We are hoping that it will be released. But I listened to Kwame some time ago about breaking the numbers down, and suddenly it looks woefully inadequate. How then do we bridge that gap and sustain it going forward? What I've realized, how we can call it, is that because of that declaration or that pronouncement, we have had an influx of more patients coming to take advantage of it. So the initial estimates that were done will be outrun in a short while. So what do? We say that the government must step in, have some more dedicated funds, look beyond what is there now, and say that, can we be involved in procuring consumables? Because if we do that, we are looking at lower prices and economics of scale, so that we can drive the price of consumables and then drive the cost of dialysis and make it sustainable. One of the key points, again, is to make sure that the transplant bill, which is the ultimate for all of these conditions, including renal failure, is transplant. That is the ultimate. It is rudimentary in this country. There's no regulating it. We are doing it. Recently, UGMC did their first one. But the bill is in the preparatory stage. We are urging them to make sure that they promulgate it in the shortest time to regulate the space and encourage persons, who need that service to receive it to prolong their life. Evans.
Prof, thank you very much. And Mr. Fair, what about you in terms of finance? I want to hear from you. You have the final word.
Financing, I think I align with, so our position has also been that we don't need to look for financing anywhere new. Release the money that is due the NHIA.
But would that be enough?
Yes.
Will that take you to the Abuja declaration?
It will be significantly enough.
Well, the nurses and midwives disagree that it won't be enough. Even if you get the 15%
it's fine.
capping.
It's fine. We can release it. We can add the 2% to it. It makes it even better. But to start with, let us release the monies that is due them. Let us remove the cap. Let us see how far we go. Let's see whether there's a gap, and then we can think about what else we need to do for that. So I think that is extremely critical, and that is, I think, relatively easier to do. So we need a firm commitment on that. And I think that, to be honest, I think that if that is done, a lot of the health-related issues significantly will be addressed. So that is a key priority. I just wanted to address a couple of things. Number one, my colleagues have talked about retention of staff. You don't
have that problem, right?
Not yet, but we'll soon have that. But there are two things. Number one is that I think the health sector, not to prioritize over other sectors, but I think that special care should be taken to make sure that we are retaining a lot of the people in the health sector. Because without good health, there's nothing else that we can do. COVID taught us that. When COVID struck, everything came to an end and our priority was just getting healthcare back before everything else can happen. So I think that we need to, preferentially treat healthcare professionals. I mean, it's not to say that other people are not important.
By doing what exactly? Paying them more?
Making sure that they are adequately paid to make sure that it is worth being
adequate here. Is very relative. What is adequate? $500
well, we have to,
an average?
No, I don't want to put a figure to it here, but like the prof said, we need to, we can look at that, what that means in particular, because not just 500. What does 500 mean? It's about the value. If somebody is going to a certain community, you are taking something away from that person. What compensation can we give to this person so that those people in that community can have access to care, and that person also doesn't seem to lose out on his life? So it's a more deeper conversation. However, there must be a commitment that we are going to do something about it. And that's it. But it's just to Evans, two things. One, specialist training is important for healthcare professionals. Look, there are some medicines, I'm talking about pharmacists, for clinical pharmacists, there are some medicines that when you're in a hospital and you are giving, the window for that medicine to go into toxicity is so narrow. So whilst you are on that medication, clinical pharmacists have to be monitoring the blood levels of that medicine to make sure that you don't fall into toxicity. That is high-level pharmacy practice. And we need to have a lot more specialists in those areas, specializing in oncology care, in other care, to be able to provide adequate care to Ghanaians. So specialist training, not for pharmacists alone, my colleague has talked about nurses and doctors to have it. It's extremely important that there must be a commitment to. And my last point is on regulation. Look, the FDA is one of our star organizations in this country, and their regulatory capacity has been recognized beyond Ghana. I think that it's an institution that should continue to be supported for one reason. All these things that we are doing will not matter if at the end of the day we get the right diagnosis, we do everything right, and the medication that you are giving does not work because it is fake or it doesn't have the right quality assurance. And the FDA is the only body that has capacity to ensure that our medicines are of the right quality. So support to the FDA should continue. and even improved for that matter.
Thank you very much, Mr. Fair. But thank you very much, Dr. Tinkran. And by the way, some of the proposals, all of you are very radical indeed. And it's going to take us quite a bit to try and digest all. We're going to do that from tomorrow. I mean, I like the 2% from the oil. We're going to get the parties here, by the way, and put these to them and see if they commit. And by the way, I was going to ask, when you met them, were they receptive?
They're quite receptive, but the meetings were at the instance of
the parties themselves. Okay. We know politicians.
They are looking for votes.
Yeah, so.
Yes, but they were quite receptive.
Okay.
And whatever proposal
they listen to it. Listen, gentlemen, thank you very much. Grateful, Dr. Kwame Sapon-Sewde, and of course, Professor Evans Yeboah. Kabbalah Scientific Affair, thank you very much for coming, and Dr. Chum also. Enjoy the rest of the evening.